Bună, da.
Clar. Doamnă doctor, putem începe sau sunt mai mulți în curent?
Cred că putem începe.
Da, bine, mulțumesc. Okay. Good afternoon, everyone. I hope you are well and ready for the lecture. And if anyone is absent, please tell them to join now. I want to say that during the lecture, we will have 2 quizzes, and be attentive because you will have an answer question on today's material. And I hope you are ready, and let's make a start. Today we will discuss about the next liver pathology, about hereditary metabolic liver disease. And I think you know that is present two types of this. This is Wilson's disease and hemochromatosis. And I'm sure that most of you know that Wilson disease, at first, this is a disease due to disorders in the metabolism of copper. And I want to say that can be two types of disorders. At first, this is Menkes disease, and this is X-linked defect in transport of copper from the intestine that leads to generalized copper deficiency. In compare with Wilson disease, where is autosomal recessive disorders of copper overload. I want to present you this is Samuel Alexander Wilson. He is American-born British neurologist, and in 1902 he graduated University of Edinburgh Medical School, and in 1905 was appointed professor of neurology at the King's College Hospital. And this neurologist in 1912 described as a familial disease characterized by progressive lethal neurologic dysfunction with liver cirrhosis and the special corneal abnormalities. And this corneal abnormalities was a Kaiser-Fleischer ring. Okay, he published this description in the journal Brain in March 1912, and and the name of this original article was a progressive lenticular degeneration as a familiar nervous disease associated with cirrhosis of the liver. About Wilson disease, I want to say that this is progressive lenticular degeneration, autosomal recessive, and in 1993 was described ATP7B gene in the chromosome 13, and this chromosome is implicated in pathogenesis and developing this disease. Failure of excretion of copper into bile is characteristic for Wilson disease. Failure to incorporate copper to ceruloplasmin can be serum-free copper toxicity and deposit of copper in brain, liver, kidney, cornea, and other organs. In continue, we'll discuss about all of this situation. I want to present you at first the normal copper metabolism. You know that about 5 milligram copper can be generated by food intake. The estimated daily copper requirement for an adult is 1.3, maybe 1.7 milligram, whereas a normal daily Western copper intake is 2-5 milligram of copper. Therefore, the amount of copper absorbed by the intestine and retained in the body must be required to prevent accumulation of excess of copper, which is toxic. The main regulatory system for maintaining copper balance in the body is the excretion of up to 80% of absorbed copper in the bile. Okay, here is. Up to 1.2, maybe 1.7 milligram day of copper is excreted in the bile daily. Okay, where is my pointer? Here. But there are also several chemical factors that impair intestinal copper absorption, such as excess zinc or ascorbic acid. Dietary copper is absorbed into the small intestine epithelial cells, where it complexed either to the protein, metallothionein, or to amino acids for transported into the portal circulation. Once in the portal circulation, the copper complexes to albumin or amino acids, and with only a small fraction remain free, maybe about 5%. What happened in Wilson disease? At first, you should know that absorption of copper is normal. There is no incorporation of copper into ceruloplasmin and not is excreted into bile. The excretion of copper in bile is decreased. An increased copper concentration in the hepatocytes results in an overflow of copper into the blood. Consequently, free copper plasma concentration is increased. And this situation, increased free copper plasma concentration, will lead to an increased urinary concentration, and excretion of copper via the stool is decreased, but increase the excretion of copper with urine. What happened at the cell level? This is a hepatocyte. Yes, Wilson's disease was caused by mutation in the ATP7B gene at the chromosome 13. The absence of diminished function, or maybe diminished function of ATP7B results in accumulation copper in the hepatocyte. This is copper, yes? And but this can happen due to types, maybe impaired copper excretion into bile and inability to incorporate copper in ceruloplasmin. The mechanism of toxicity of copper at the cellular levels may be due to genetic defect, which we discussed, and as a result, excess of copper destroys the hepatocytes and deposits in tissues. What happened in the early stages at the tissue level? At first, we can find the steatosis, focal necrosis, maybe glycogenated nuclei in hepatocytes and apoptotic bodies. And the last stages where happened parenchymal damage, we can find the lobular necrosis and periportal fibrosis. Wilson disease, epidemiological, we can characterize it by as a genetic disorder that found worldwide, and incidence may be as high as 1 in 30,000 people. And we know about 500 different mutation at the level of ATP7B, but only 380 mutation have a confirmed role in the pathogenesis of the disease. And I want to say that Wilson disease is not just a disease of children and young adults, but in majority, clinical presentation is between ages 5 and 35, and was described the first case of the youngest patient was with cirrhosis due to Wilson disease at the 3 years old, and the oldest patient was diagnosed in their age decade. About clinical features, I want to tell that we can find the ocular signs, the clinical hallmark. This is clinical hallmark of Wilson disease, and which is present in 95% of patients with neurological symptoms, and somewhat overall of those without neurological symptoms. And we should know that in children presenting with liver disease, Kaiser-Fleischer ring are usually absent. About 40% of clinical features is hepatic presentation. Can be neurological presentation in 40 or 50%, psychiatric, and about 10% of people can be asymptomatic. I want to show you ocular sign. This is caused by copper deposition in the distal membrane of the cornea. And we can see these rings usually on iris pigmentation is light or if copper deposition is heavy. But all of patients should be examination with slit lamp. And we discussed usually about that only 5% of patients do not present this sign. Another ocular sign is sunflower cataracts. This is caused by deposits of copper in the center of lens. And in this case, we should examine the patient with slit lamp. About hepatic presentation. Presenting symptoms of liver disease can be highly variable, ranging from asymptomatic, which only biochemical abnormalities, to over-cirrhosis with all its complications. Wilson disease may also present as acute failure, sometimes associated with Coombs negative hemolytic anemia and acute renal failure. Patients diagnosed with Wilson disease who have a history of jaundice may have previously experienced an episode of hemolysis. I want to emphasize sometimes can be severe chronic liver disease with hepatosplenomegaly, ascites, a low serum albumin level, and maybe abnormal coagulation test results. In children and young adults with clinical liver disease may be indistinguishable from autoimmune hepatitis. In this case, we should apply the specific markers like immunoglobulin G and autoantibodies anti-ANA or anti-ASCA. If they will be present, we can say that this patient has an autoimmune hepatitis. And maybe recurrent bouts of hemolysis may predispose to the development of gallstones. Children with unexplained cholestasis should be tested for Wilson disease because this can be due to accumulation of copper. And we should know that sometimes can be present hepatocellular carcinoma, and this situation was reported in a child with Wilson disease, especially with cirrhosis due to Wilson disease. Next is neurological presentation. Neurological signs are variable. Neurological presentation can be extremely subtle and intermittent for many years, but may also develop very rapidly, leading with a few months to complete disability. And this presentation occur in the second, maybe in the third decades of life. Can be two types, movement disorders and maybe rigid dystonia. Movement disorders is characterized by tremors, poor coordination, loss of fine motor control, and rigid dystonia is characterized by mask-like faces, rigidity, maybe pseudobulbar involvement like dysarthria, drooling, swallowing difficulty, maybe can be present. In many cases, neurological signs are very difficult to classify as patients can have more than one abnormality, it with different level of severity. 20% of patients may present with poorly psychiatric symptoms, and behavioral and psychiatric symptoms are common, and some of them may precede neurological or hepatic signs or symptoms. About 1/3 of patients initially present with psychiatric abnormality, but the initial symptoms are frequently misdiagnosed as behavioral problem associated with puberty. Patients presenting with neuropsychiatric symptoms may have concurrent symptomatic liver disease, but in most patients, liver disease can only be detected by laboratory evaluation. Imaging may be due to imaging test or maybe by liver histology. And other systems. Coombs negative hemolytic anemia may be the only initial symptoms of Wilson disease. However, marked hemolysis is commonly associated with severe liver disease. Sometimes low-grade hemolysis may be associated with liver disease, even when liver disease is not clinically evident. Some patients presenting with neurologic symptoms report that they have experienced transient episodes of jaundice previously, and probably due to hemolysis. Here I present you all of hematological problems which can be due to Wilson disease. Less common presentation include renal with nephrolithiasis, skeletal with premature osteoporosis, maybe arthritis, can be cardiomyopathy or arrhythmias due to changes in the cardiovascular system. The same can be pancreatitis, hypoparathyroidism, and infertility. We know three clinical forms of Wilson disease. Can be hepatic form, isolated hepatic form, another hepatoneurological form, especially this is Wilson disease, classic Wilson disease, and neurologic form. Wilson disease accounts from 6–12% of all patients with acute liver failure who are referred for emergency transplantation. This is very important to know because isolate hepatic form, this is very severe form. And acute liver failure due to Wilson disease varies as almost 95% mortality rate. Okay, for us it's very important question. How can we establish the diagnosis? At first, we should do the liver function tests. I think you know all of these tests. We should to check if a liver problem is present. You should to do all the markers of clinical syndromes, hepatic syndromes. Then, next step is a specific biochemical test for establish if metabolism copper deficient maybe problems is present. Hepatic parenchymal copper concentration we should to check. Maybe liver biopsy can help us. Neuroradiological imaging, and at last time we should to apply genetic test. I want to present you specific biochemical test. This is ceruloplasmin concentration, copper, serum copper concentration, hepatic copper, and urinary copper excretion in 24 hours. This is specific characteristical biochemical test for copper metabolism. At first, this is serum ceruloplasmin, is the most carrier of copper in the blood. Ceruloplasmin synthesized in the liver, and this is acute phase reactant. It contains 6 copper atoms per molecule. This is hollow ceruloplasmin, but may be present just as a protein without the copper. This is apoceruloplasmin, and can be a disturbance because that. Immunological assay may overestimate ceruloplasmin concentration since they do not discriminate between apoceruloplasmin and holoceruloplasmin. Normal value is between 18 and 35 milligram per deciliter. And in case if serum ceruloplasmin is lower than 20 milligram and if it's present Kaiser-Fleischer ring, we should consider this patient for Wilson disease. And if ceruloplasmin will be lower than 5 milligram, this is strong evidence of Wilson disease. But we should know that only subnormal levels needs further test to confirm the diagnosis. And normal level doesn't exclude Wilson disease. Next test is serum copper. Normal of or elevated serum copper levels in the face of decreased level of ceruloplasmin indicate an increase in the concentration of copper, which is not bound to ceruloplasmin in the blood. To calculate the free copper level, which for that the ceruloplasmin is multiplied by 3, and this value is then subtracted from the total serum copper level. The serum not ceruloplasmin bound copper concentration has been produced as a diagnostic test for Wilson disease. Normal level of serum copper is lower than 1.6 micromole per liter. Next specific test is urinary copper. This is excretion. Yes, this is a very important diagnostic and monitoring test. Basal 24-hour urinary copper, more than 100 microgram, is symptomatic Wilson disease. But if value is more than 50 microgram, may indicate Wilson disease, but we should apply another test to confirm the diagnosis. And here I show you the depenicillamine challenge test. Urinary copper excretion with depenicillamine administration was thought to be a useful diagnostic test, but this test has only been standardized in a pediatric population. How should you do? You should give for your patient 500 milligram depenicillamine orally at beginning, and then you should repeat the dose after 12 hours. And then you should collect 24 urinary urine and detect the copper. If copper will be more than 1,600 microgram, we consider the test is positive, and this is confirmation test for diagnosis. Next, this is hepatic copper. Normal value is less than 4 micromole per gram for dry liver tissue. Critical value is more than 25. You can see that it's very big difference between 4 and 25. And further evaluation needed if the value of hepatic copper will be between this value. And about liver biopsy, I want to tell that for diagnostic purpose, a liver biopsy is only required if the clinical signs and non-invasive tests do not allow a final diagnosis of maybe if we have a suspicious for the other liver pathologies. I want to present you that specific test about we discussed can be false negative and false positive. Serum ceruloplasmin can be false negative in case where normal levels can be in patient with marked hepatic inflammation. Maybe we discussed usually about that overestimation by immunologic assay. In pregnancy patients and where your patient take estrogen therapy. And can be false positive in malabsorption, aceruloplasminemia, and in patient who is heterozygotes. Next test, 24-hour urinary copper, can be normal in case if it was incorrect collection or in children without liver disease. And the same excretion of copper by urine can increase in the hepatocellular necrosis, cholestasis, and in the contamination. About serum-free copper, I want to tell that can be normal if ceruloplasmin overestimated by immunologic assay. Next test, hepatic copper, can be false negative in patient with active liver disease or in false positive in cholestatic syndrome. The same situation is with Kaiser-Fleischer rings. Up to 50% of patients with hepatic Wilson disease, hepatic presentation isolate, is present without Kaiser-Fleischer rings and in most asymptomatic siblings, and can be false negative, positive in primary biliary cirrhosis, or you know about primary biliary cholangitis. At final step of diagnosis is mutation analysis. Mutation analysis by whole gene sequencing in patients who have clinical or biochemical testing at the borderline. We discussed about the mutation, at which level is. I want to show you here is the most common mutation and we were found this mutation. Most common for the Central Europe is H1069Q mutation. Okay, next step is neuroimaging examination. Magnetic resonance imaging or computerized tomography of the brain may detect structural abnormalities in the basal ganglia. The most frequent findings are an increasing density of computerized or hyperintensity on MRI in the region of the basal ganglia. MRI, I want to tell that MRI may be most sensitive in detecting these lesions. Significant abnormality on brain imaging may even be present in some individuals prior to the onset of symptoms. This is diagnostic approach to Wilson disease, and you can see that at first step, we should to apply the clinical evaluation of patient about hepatosplenomegaly, maybe other clinical signs, especially Kaiser-Fleischer ring. Liver test to confirm presence of liver pathology and specific biochemical test of copper metabolism. We discussed about serum ceruloplasmin, and most common is 24-hour urinary copper excretion. Next step is molecular test And the last step is liver copper concentration. A diagnostic score, this diagnostic score is based on all available tests, was proposed by the working part at the 8th International Meeting of Wilson Disease in Leipzig in 2001, and the Wilson disease scoring system provides a good diagnostic accuracy. You can see here the typical clinical symptoms and signs and other tests. 4 typical signs can be Kaiser-Fleischer rings, neurological symptoms, serum ceruloplasmin, and Coombs negative hemolytic anemia. And as a prognostic index, I won't present you due to European Association for Study of the Liver Disease. And this is important because you know the child score, like child score for cirrhosis, this is the same for Wilson disease. And this score includes some biochemical marker, serum bilirubin, AST, INT, white blood cells, and albumin. And the score greater than 11 is always fatal without liver transplantation. Next. Okay, we should know about the population who should be investigate for Wilson disease. This is all of patients with mimic liver disease, all of young and adult patients with maybe with autoimmune, maybe with clinical presentation of autoimmune hepatitis, who not responding to steroid treatment, maybe with is patient with hepatic steatosis, with NAFLD, and some patient with acute liver failure, but with presentation with presence of Coombs negative hemolytic anemia, maybe with intravascular or renal acute failure. The same we should to do the screening, family screening. This is for first degree relatives and parents of child newly diagnosed with Wilson disease. At first, we should to check if Kaiser-Fleischer rings is present, and maybe next test will be 24-hour urinary copper. And the last will be ATP7B mutation analysis. This is important. The newborn screening should apply until 1 to 2 years of age, and a specific test for newborn is serum ceruloplasmin and only simple urine analysis. Next, we will decide if you need another test to confirm or infirm the diagnosis. The importance of family. It is essential to screen the family of patient with Wilson disease because the chance of sibling being homozygote and therefore developing clinical disease is 25%. And assessment of this person include at first physical examination, maybe examination, a specific test to establish if liver disease is present. Then will be serum ceruloplasmin, liver functional test, but this test should be at first, and then molecular test of ATP7B mutation of haplotype study. Okay, this is a scheme presentation. What should we do when we have a patient with unexplained liver disease? At first, we will test the serum ceruloplasmin, 24 urinary copper excretion, and slit lab examination. According to that, we have 4 types of results, and first is with Kaiser-Fleischer ring present. ceruloplasmin lower than 20 and excretion of copper more than 40. In this case, diagnosis of Wilson established. In other case, when is present Kaiser-Fleischer ring, but ceruloplasmin is more than 20, but excretion of copper is more than 40. In this case, we should do liver biopsy with copper quantification. As a result, independent of the result of that, we'll decide diagnosis will be established or we should apply a molecular test. Another situation when Kaiser-Fleischer ring is absent, but ceruloplasmin is lower than 20 and excretion of copper is lower than 40. In this case, will be liver biopsies and maybe quantification of copper in the tissue of liver, and independent of the result, we will decide if we establish diagnosis, maybe we need a molecular test or this is other diagnosis. Another situation when Kaiser-Fleischer rings is absent, but copper ceruloplasmin is lower than 20 and excretion of copper more than 40. In this situation, we should do the liver biopsy, and independent of that, we decide about diagnosis. And finally, when the diagnosis was established, next question for us will be, how should we treat? Treatment. The aim of the treatment in this case is to remove the accumulated copper and prevent further copper again. In this situation, help us anti-copper drugs like dipenicillamine, zinc, trientine, and tetramolybdate. But not only drugs. Diet is important, drinking water, hepatic management, neurological management, and at the finally can be liver transplantation. Diet. What is important? Should be avoid shellfish, nuts, chocolate, mushrooms, and organ meat, because all of these products contain very high level of copper. Next, copper chelation drugs. At first is dipenicillamine, is rapidly absorbed from the gastrointestinal tract. And we should to give the patient about 250 to 500 milligram per day, and every 4-7 days we can increase the dose if will be necessary. The highest maximum dose is 1.5 gram per day, but should divide this dose in 2 or 4 doses. And we should to know that dipenicillamine should take with pyridoxine. The same, this is very important to know side effects of dipenicillamine, like fever, rash, aplastic anemia, nephrotic syndrome, hepatotoxicity. And if dipenicillamine is taken with a meal, its absorption is decreased overall by about 50%. And in case of severe side effects will be present, dipenicillamine should be discontinued immediately. Okay, next drug, we should discuss about trientine. Trientine was introduced in 1969 as an alternative treatment to dipenicillamine. Is a chelator with polyamine-like structure chemically, like dipenicillamine, trientine promotes urinary copper excretion. The dose of this drug is 750 to 1015 milligrams, should to divide in 2-3 doses. And this drug, the same, has some side effects. Another is zinc, and was first used to treat Wilson's disease in Holland in the early, was used earlier than 1960. Its mechanism of action is different from that of penicillamine or trientine. Zinc interferes with the uptake of copper from the gastrointestinal tract. Once bound, the copper is not absorbed, but is lost into the fecal contents. Zinc may have a role as a first-line therapy in neurological patients. And next drug is tetramolybdate. Tetramolybdate is a very strong decoupling agent and complexes with copper in the intestinal tract and prevent the absorption of copper. But you should know that this drug is experimental in the USA and Canada. About some treatment options, I want to tell that symptomatic Wilson disease patients has two phases of treatment: initial intensive treatment and maintenance phase treatment. For initial, we should to give them oral copper chelators and typically take 1-2 years. And maybe some patient with severe neurological disability should take these 3 years. And maintenance phase, we should continue lifelong oral copper chelators. Next, another situation where we detect asymptomatic patients. We start with maintenance treatment, and oral copper chelator will be for lifelong. A specific group is the pregnancy patient. We should know that at first we need to optimize the treatment before planned pregnancy, then continue oral copper chelator with adjust the dose. And another important tip is avoid breastfeeding post-pregnancy, because as both the oral copper chelators and zinc cells are secreted in the breast milk and may interfere with the infant's copper metabolism. About hepatic transplantation. In Wilson disease, liver transplantation is a life-saving, curative treatment that provides functional hepatic ATP7B protein and enables the restoration of normal hepatic function. It is the gold standard treatment for fulminant hepatitis or decompensated liver cirrhosis. It also has a role in case of liver adenocarcinoma that cannot be removed surgically. The indication for liver transplantation in the context of neurological deterioration without liver filiary is a controversial, but has been little studied. A recent pilot study suggested that liver transplantation could probably be useful in severe neurological forms that are resistant to well-conduced chelator therapy. And about prognosis, I want to tell that Wilson disease has a fatal outcome if not treated appropriately and in a timely manner. And symptomatic Wilson disease patients require lifelong treatment because an interruption of therapy or inadequate treatment can lead to fatalities within 9 to 3 years. Okay, now it's time for a first quiz, and I will copy this quiz and I will put in your chat. Wait only only few minutes. I will put the quiz in the chat and you can access this quiz. Then please send me your answers. After that, we can do the break about 10, maybe 15 minutes, and then we will continue with other pathology. Everything is okay? You can access the quiz? Okay. You can do this, and after 15 minutes at 13:05 we will start second part of lecture. Okay, I want to say that all of you should send me answers because this will be the confirmation of your presence on the lecture. Please do this quickly. Okay, now I have 35 answers, and I'm glad that a big part of this is correct. A big part have 100 points for this quiz. This is, I think, due to your attention. And now I want to continue the presentation, and the next part of our lecture will be about hereditary hemochromatosis, and this part will be about the metabolism of iron. Okay, what is hereditary hemochromatosis? This is the abnormal accumulation of iron in the parenchymal organs, such as liver, pancreas, skin, maybe heart, and leading to organ toxicity due to free radicals generated by iron. But this is a definition of hemochromatosis in general. Hereditary hemochromatosis is most common autosomal recessive genetic disorder. What happened? Do you have a problem? Because I can see the chat. Please wait a second. I'll try to see what the problem is. Oh, yes. This is a problem at the level of chromosome 6. Yes. Okay. Also, hemochromatosis known as a Celtic chart or bronze diabetes. And on the next slide, you have a French physician, Armand Trousseau. In 1865, he gave a lecture about glucosuria and a new syndrome presenting with diabetes, with liver cirrhosis, with yellow-gray granules and brown skin pigmentation of patient in 36 years old male. And he published this clinical case in Clinic Medical Journal. The same overview I want to say that named hemochromatosis in 1889 was due to Recklinghausen, and in 1935 Sheldon inherited detect in iron metabolism. Then later in 1976 Simon described the short arm of chromosome 6 in the HLA system. Okay, then later in 96 was identified the HFE mutation at this level. And most common mutation characteristic for hemochromatosis is C2A2I and HC3D mutation. But now we know about other mutations, and specific is mutation at the level of ferroportin, transferrin receptor, hemojuvelin, or mutation at the level of hepcidin. About epidemiology, I want to say that hereditary hemochromatosis remains the most common genetic disorders in Caucasians. Women typically presented approximately 10 years later than men, the clinical manifestation of the disease due to specific situations. And the report between female and male is about 1 to 10. And population screening has shown prevalence of heterozygotes. About 10% of mutations are characteristic for hereditary hemochromatosis. I want to present you the body iron metabolism. And remember, please, that iron uptake and recycling every day, yes? Most of the utilized body iron is recycled from sinistrate erythrocytes by macrophages and returned to the bone marrow for incorporation in erythroid precursors. The liver and reticuloendothelial macrophages function as major iron stores. About 1-2 milligram of iron is absorbed and lost every day. The liver produced peptide, the specific peptide, hepcidin, and which can control the plasma iron concentration by inhibiting iron export by ferroportin from erythrocytes and macrophages. This means that an increased hepcidin production leads to a decrease in plasma iron concentration. On this picture, I want to show the most common organs where iron will be accumulated. In the liver, yes, in the erythrocytes, in the bone. Erythrocytes, it's not only erythrocytes and macrophages too. In the muscles, this is a most common location. I want to present you the hepcidin, which is a protein, which is synthesized by liver, and concentration of this hepcidin regulation is regulated by iron stores, inflammation, maybe erythroid iron damage, and maybe due to hypoxia. About pathophysiology, the excessive absorption of iron leads to cellular injury, so the Fenton reaction will generate oxyradicals. They in turn lead peroxidation of organelle membranes. Progressive deposition of iron in the liver can result in fibrosis and ultimately cirrhosis. In the early hereditary hemochromatosis, iron remains localized within hepatocytes along the pericanalicular axis of the cell. Increasing level of hepatic iron increase the risk of cirrhosis, and maybe age and duration of iron loading have been shown to play a significant role in the development of advanced fibrosis. Okay, here I want to present the schematically pathogenesis in the hemochromatosis due to HFE mutation. In this case, the concentration of hepcidin will decrease in compare with normal situation, and due to this will decrease the control to transport of iron due to ferroportin. And concentration of iron will increase in plasma and will be absorbed will be absorbed from macrophage and abdominal enterocytes. About classification, I want to say that can be two types of hereditary hemochromatosis. At first is HFE-related hemochromatosis and non-HFE related. Here you have the most common mutation, which can characterize the HFE-related hemochromatosis. And in case if will be non-HFE, mutation will be like hemojuvelin, transferrin receptor, ferroportin, and maybe hepcidin mutation. Another part can be other iron overload syndromes, but this will be a secondary due to other causes. When present, expressive alcohol consumption or chronic infection with virus C and obesity-related steatosis have been shown to act as a cofactor in development of fibrosis and cirrhosis. And in this case, can be iron may be a cofactor in exacerbation of liver injury. The same alcohol-induced ferritin synthesis. But in this case, they revert to normal, usually after, I think, about 3-4 months for abstinence. What about metabolic syndrome? It is one of the most frequent causes of hyperferritinemia today, that is often accompanied to normal transferrin value. This condition is also named insulin resistance associated iron overload, of maybe this metabolic hepatosiderosis. Ferritin level may be elevated up to maybe 1,200 in this case. Can be some inflammatory conditions. In this case, hyperferritinemia is associated with low transferrin levels. Anemia can be present, corresponding to the classical anemia of chronic disease. Therefore, plasma inflammatory markers should be checked. Sometimes in acute or chronic hepatitis, where happen the hepatocyte damage, intracellular ferritin can be released into the bloodstream due to either real membrane damage or altered membrane. In this situation, sorry, one moment only. Okay. In this situation, can be significant hyperferritinemia, can be cytolysis, but we can found another parameter increase. Other parameter can be increased due to this to inflammation. Okay, another chronic situation is parenteral iron overload due to blood transfusion repeated when we repeat very frequently blood transfusion, maybe due to iron injection or in patient with the long term of hemodialysis. We can discuss about the spectrum of disease, and phenotypic expression only occurs in approximately 70% of C to A2I homozygotes, and fewer than 10% if homozygotes will develop severe iron overload. Due to European guideline of study of liver disease, we know 3 stages of disease, and first is genetic hemochromatosis. This is only abnormal genotype, but in this case is not increase the iron stores. We can detect only genetic abnormalities. And the second stage, this is biochemical stage of hereditary hemochromatosis. We can find overload of iron. Genetic test will be positive, but in this case will be without tissue or organic damage. And next stage, the third stage is clinical hereditary hemochromatosis. In this case is symptomatic disease, and we can find all the signs: Genetic disorders will be present, iron overload test will be positive, and tissue and organ damage the same. Here I want to present the natural progression of the disease. And you can see here that the clinical situation of the disease occur only about the 30-40 years, because during the years from the born to the 30 or 40 years, only is accumulation of iron in the body. Clinical manifestation is common in 58% of patients, and all of the symptoms will be due to accumulation of iron in the organs. And the first can be liver function abnormalities in 75%, then weakness and lethargy. It depends if the iron will be deposited at the level of nervous system. Skin hyperpigmentation, diabetes mellitus will be in 48%. Arthralgia, impotence, and in some cases can be electrocardiographic abnormalities due to accumulation of iron in the heart. Hepatic manifestation can be different. You know that liver is usually the first organ to be affected, and due to that we have about 75% of liver function abnormalities test. The most common manifestation is hepatomegaly and some characteristic hepatic symptoms. But the difference between hemochromatosis effect and other etiological factors of liver problem is a little bit different. Portal hypertension and esophageal varices occurs less common than in cirrhotic patients due to another etiological factor. But in this case, you should know that about 30% of patients with hemochromatosis, with cirrhosis, especially due to hemochromatosis, can develop the hepatocellular carcinoma. And incidence of hepatic manifestation, incidence of complication increase with age, maybe most common is for men and almost exclusively in cirrhotic patients. About the skin, manifestation is pigmentation, and for this patient is characteristic metallic or slate gray hue. This is results from increased melanin and iron in the derm. Usually pigmentation is generalized, but we know the most pronounced part of the body. This is a face, neck, maybe genital region, in the region of scars. This is the most affect part of the skin. Diabetes can occur in about 65% of patients, and more likely to develop in those with a familial history of diabetes. And it is important that if you have a patient with diabetes, with insulin resistant, we should to check this patient for hemochromatosis, because maybe hemochromatosis can be present in this case. Another part of clinical presentation is arthropathy, and this sign develops in 25-50% of symptomatic patients and usually occurs after age 50. Frequently, the involved joints is second and third metacarpian joints, and changes is due to accumulation of calcium pyrophosphate at this level. Here you have a radiological presentation of accumulation of calcium pyrophosphate at the level of second and third metacarpian joints. Another part is cardiac involvement and can be present in about 15% of patients. And most common manifestation is congestive heart failure and cardiac arrhythmia. Most frequent, we can find premature supraventricular beats, maybe proximal tachyarrhythmia, atrial flutter, atrial fibrillation, and atrioventricular block in different stages. The same can be hypogonadism and occur in both sexes and present with impairment of hypothalamo-pituitary function due to iron deposition at this level and characterized by loss of libido, impotence. For women is characteristic amenorrhea, for men testicular atrophy, can be gynecomastia and sparse body hair. Okay, about clinical characteristics of hereditary hemochromatosis, I want to tell that clinical presentation is most common in patient homozygotes with mutation C2A2I and can be in heterozygotes with combination mutation situation with H63D. Where we have a patient with heterozygote mutation or isolate homozygote mutation H63D, these mutations no increased risk of disease. What's the difference between sexes? In men, clinical disease rare appear before 40 years because I show you naturally progression of disease, and about 40 years need to accumulate about 10 or 20 grams of iron in the body. What is characteristic for women? Clinical disease reappear before menopause and because the menstrual blood losses offset iron accumulation. For the diagnosis is very important. About 35% give the symptoms which we found at the patient. Another 45% is due to abnormal laboratory test. And finally, maybe about 20% will be family member with hemochromatosis. This is all of reasons for diagnosis. But we should remember that not all iron overload is hemochromatosis. We discussed about that earlier. And not all patients with mutation C2A2I have a clinical disease or shortened life expectancy. Okay, for diagnosis, we should to suspect disease clinically, we should to apply biochemical test, and then maybe we need to apply the genetic confirmation. Here I want to present you the specific biochemical test for iron overload. At first, this is transferrin saturation, should be more than 45%. This test has a very high specificity and sensitivity, about 94%. Next test is ferritin, should be more than 300 microgram per liter. Normally, we found this test about 40 to 100 microgram per milliliter. But this test has lower sensitivity, about 50%, but the same is very high specificity, 88%. And you can see here that can be the difference between the premenstrual women and postmenstrual women. Okay, these tests indicate primary iron overload. And you should remember that false positive elevation related to inflammation. In the absence of increased iron stores in patients with necroinflammatory liver disease, all of necroinflammatory liver disease can lead the iron overload. What about liver biopsy? Liver biopsy is not specific to establish a diagnosis. Maybe in some cases we can find hepatic iron load, but most common is to detect if it's not present in other disease of liver. Now mainly used if genetic test unavailable or not diagnostic. Okay, here is a genetic confirmation. We should detect the mutation test for all patients suspected of iron overload. Screening. In which group we should apply the screening? At first, we have a high-risk group. This is a asymptomatic patient. This is patient with family history, maybe with family history of hereditary hemochromatosis. All of the first-degree relatives should be tested for hemochromatosis. Those with suspected organ involvement. Maybe in individuals with unexplained elevation of liver enzymes or asymptomatic hepatomegaly. Optimal timing for screening family members is between the age 18 and 30. Generally recommended that all patients with abnormal liver function have iron studies down at point. All of patients with the hepatic problems, and in case if we don't know about the etiological factors, we should to do the screening test for hemochromatosis. And another part of screening population is symptomatic patient. At first, this is patient with unexplained liver disease or presumptible known cause of liver disease with abnormality or iron or more iron markers. Patient who has type 2 diabetes mellitus, especially with hepatomegaly, with elevated liver enzymes, maybe with a typical cardiac disease. Maybe, if you remember, I said this is patient with insulin resistance. And another part, this is early onset atypical arthropathy, cardiac disease, maybe mild sexual dysfunction. All of these patients should be tested for hereditary hemochromatosis. Here I want to present to you the diagnostic algorithm of hereditary hemochromatosis. At first, will be clinical suspicious and diagnosis of iron storage disease. Then we should apply the ferritin concentration and transferrin saturation. And then if the ferritin will be more than 30 for men and more than 200 for women, transferrin will be more than 50%, we should apply the HFE mutations. And then we'll detect about the type of iron overload. Next step is treatment. Goal is iron depletion in order to prevent the complication, maybe in patient with early iron overload. And if we can, we should reduce reversible consequence of hemochromatosis. Maybe this will be for patients which have a clinical disease. And if in case of patient with Wilson disease, we discovered that this is very important. Some rules in diet. In this case, dietary adjustments are unnecessary due to metabolism of iron, especially. Only you should remember that vitamin C supplements and iron supplements should be avoided because this will be adapt form and can increase absorption of iron. Especially about treatment, phlebotomy. This reminds us so recommended treatment because it's simple, inexpensive, and safe. This treatment has two phases. First will be induction phase and maintenance. For induction, we should do one phlebotomy, about 500 milliliters of blood, 1-2 per week, and then we should check the level of hematocrit. Do not allow hematocrit fall by more than 20% of prior level. And after every 10-12 phlebotomies, we should check level of serum ferritin. Then will be maintenance phase. This include the phlebotomy every 2-4 months, and we detect when we will do the next phlebotomy. It depends of concentration of ferritin, which should be 50, maybe 100 microgram per liter. Why we do this? Because phlebotomy improved sense of well-being every level, the cardiac function, control of diabetes, improve the hepatic function, can reduce of tissue iron stores to normal, and the secondary can reduce the portal hypertension in patients with cirrhosis, maybe reduce the skin pigmentation. The same phlebotomy can be reversal for hepatic fibrosis. About 30% was reported from the cases, but this is for fibrosis till to second, maybe third stage of fibrosis. And it is not reversible of established fibrosis or established diabetes. Maybe can control sometimes, but not reversible. And the same phlebotomy can reduce the risk of hepatocellular carcinoma due to hereditary hemochromatosis. Another part of therapy is chelation therapy. This applies only in some cases. When our patient has another diseases, maybe heart disease, anemia, maybe in case if we have a poor venous access, we can use a deferoxamine. This is drug to use intravenous or subcutaneous 5 days per week. Another case, we can use deferasirox. This is orally drug, and the same administered once 5 times per week. But you should know that all of these drugs very efficient in liver removal of iron and less effective in the splenic and pancreatic iron. The same, these drugs have a very has a different side effect, and all of patients should to check for the renal function because can develop the insufficiency or renal failure. Prognosis. In case if we have a pre-cirrhotic patient with hemochromatosis, especially they have a normal life expectancy. And in case we detect the hemochromatosis in cirrhotic patient, these patients have a relatively good prognosis as compared to other form, because we discussed about that earlier. And all of patients should be checked periodically, should be checked for hepatocellular carcinoma, because the third part of patient with cirrhosis can develop this complication. And now it's time for next quiz. Now I will try to put this quiz in your chat, and please, I will give you 5 minutes, 6, not more than, to resolve this and send me. And please, in this case, is the same situation. Who will resolve this quiz? I consider that will be at the lecture. Everything is okay? Can you try the address?
Doamna conferențiar?
Da, da.
Da, am oprit înregistrarea.
Nicio problemă, eu încă aștept rezultatul.
Nu știu dacă e posibil, poate îmi trimiteți varianta și țină scelca.
Bine, da.
Adică să o avem pentru orice eventualitate, parcă avem întreg și în timp, dar mă rog, să avem...
Bine, că eu, iată, de la cursul trecut n-am păstrat varianta Excel.
Nu, dar mă rog, ne modificăm și noi cu atitudine.
Ok, da.
Hai, sănătate multă, la revedere!
Da, eu vă zic că la revedere, eu îi aștept pe dâns să trimite răspunsurile. Okay, please quickly if it's possible, because now I have only 3 answers. And now Miss Angela said that I should to present for her all of your results.
We finished?
Wait, please, because now I have only 6 answers, and if you can, and if you want, please tell to all of your colleagues that if it's no send me the answer, I can't consider the presence of the course. Because Miss Angela now tell me that I should to present for her all of the results. Now I have only 6 answers.
Okay, but who finished answering can go?
Yes, I think so. It's if you don't have a questions, please. It's not a problem.
Thank you, doctor. Have a nice day.
Have a nice day too. I want to tell for all that in 3 minutes I will close the possibility to give me the answers. Please quickly do it. Okay, now I have 28 answers, and I will close the possibility to send me your answer. And who didn't send now will be considered that was absent at the lecture. 29. Why should I wait? Why should I wait a minute? How can you know?
Doctor, I'm having some difficulties with the connection. I'm trying to solve it, and I will, as fast as possible, I will return.
I don't. You have only one possibility to send me the answer, and I'm not sure that was a problem with connectivity because I see all of the students here, and if you have a problem, here I have was a marked who have a connectivity problem. Okay, who sent me the answer? Please, you can leave the our meeting if you haven't a question.
Doctor, I will ask my colleagues to send me the questions, and I can send the answers to you via email, if it's possible.
Wait, I'll try to check if your answer is here.
Resend the quiz, please, so I can see it because it's not shown here.
Mhm.